Thanks for that kind introduction. I'm Hiba Hefsi again. So I'm going to tell you a little bit about the TPA story. I want to start by sort of reintroducing when this originally came out. It's been over 20 years since the landmark trial was published in 1995 in the New England Journal of Medicine by the NINDS. And as you know, Henry Ford was a major coordinator for this trial. What a lot of people don't know is that there were actually two parts to the trial, and the first part was looking at patients' immediate improvement after receiving IV TPA, and the second part was looking at long-term outcomes, and there was actually no statistical difference in immediate improvement following IV TPA, and all of the benefit was really seen at 3-month outcomes. And it took a long time for anybody to really think outside the box, and for a long time, anybody who presented within 3 hours was considered for IV TPA, and anybody who presented outside of the 3-hour time window was almost forgotten about. Over 10 years later, again in the New England Journal of Medicine, another trial was published expanding the indication for IV TPA. And now we were able to show that patients who present within the 4.5-hour time window actually benefit from treatment with IV TPA. This was done in September of 2008, and unfortunately patients who are older than age 80 were excluded from this trial. So we're actually still stuck in this place where if you're 79 and you present to the hospital within 3 hours of your last known well time, you're treated with IV TPA. You're 80 years old and you have the same exact scenario and you're 3 hours or 3 hours and 5 minutes, bad luck. So somebody thought this is not right. As we know, we have an aging population. Our patients are living older than age 80. We have a lot of patients in their 80s and 90s. And what about patients who present outside of the 4.5-hour time window? Somebody thought they needed to put this idea to the test. And so in May of 2012 in the Lancet trial, the International Stroke Trialists published their results. Now this was a very large trial conducted in Europe. They had over 3,000 patients. And they were actually able to show that our 80-year-old and 90-year-old counterparts had the same exact benefit when treated with IV TPA as their younger counterparts. The other interesting thing they showed was that the benefit of IV TPA continued to outweigh the risk even when given up to 6 hours out from last known well time. So, you know, this is almost 20 years after the initial publication, but we've already doubled the time window for IV TPA and expanded its indication to include patients who are much older than we thought we could treat. So the TPA story continues. What do we do about patients who present with minor stroke? Typically, these patients are excluded from IV TPA. Someone has an NIH stroke scale of 0, of 1. They're not given IV TPA, and the focus is largely to enroll them in secondary stroke prevention trials, and we just assume that it's okay for them to live with this little disability. Well, somebody thought this is not right. And so a couple of trials have actually taken place. The first one was sponsored by Genentech, and it was done here in the US. It's called the Prisms Trial, and they looked at giving TPA to patients with minor stroke, even NIH stroke scales of 0, but still have a major disability, for example, truncal ataxia. Unfortunately, this trial was terminated early due to slow enrollment, and they have yet to publish their results, but hopefully they'll be promising. But we have not given up. Meanwhile, in Canada, where everything is colder, they conducted pretty much the same trial. It's called the Tempo 2 trial, but the one difference that they had was that they wanted to make sure that these patients with low NIH stroke scales were actually having a stroke. And so they mandated large vessel occlusion to be found to be enrolled into the trial. And so, you know, minor stroke, NIH stroke scale 0, 1, gets a CTA, has a large vessel occlusion. These patients were actually given tenecteplase. This trial is still ongoing. It's going to be completed in a few years here. But so far, their enrollment has been good, and we're hoping that they will be able to show that we're able to prevent disability at 3 months in patients with minor stroke when chosen wisely. So speaking of choosing wisely, what do we do with these patients who wake up with stroke symptoms? Typically, somebody comes to the hospital and says, I went to bed normal, it's 12 hours later, I'm awake. The ER staff will hear this story and say, oh, you're not a lytic candidate, and we just move on with life and forget about these patients. That is not the case. These patients, we have a lot to offer them, and I know there's going to be a lot of speakers who talk about endovascular therapy targeted at wake-up strokes, but what we don't know is that we can select patients with wake-up strokes to receive IV TPA. And this has actually been looked at. So the first trial that I'm going to talk to you about is called the Eyewitness trial. It was presented at the International Stroke Conference in February of 2016 in Los Angeles, and it was conducted out of Harvard Medical School. And basically, this was the exact question. How do we choose patients who wake up with stroke symptoms to safely receive IV TPA? So what they did for these patients who had no witness to their symptoms, they got a hyperacute MRI, of course, after a CT showed that there was no intracranial hemorrhage. They had 80 subjects, and basically what they were able to show is that we know that when somebody has an MRI with a positive DWI and a negative flare, it's presumed that their stroke is within 6 hours, or they are within 6 hours of their symptoms. And so these are the patients who they felt were probably, despite waking up in stroke, probably had their stroke in their sleep and were still in a very acute phase. And so they had a pretty equal distribution of patients. Half of them were men, age 67. The majority had no pre-existing disability. Median NIH stroke scale was 7.5, so these are moderate strokes. Really the most interesting thing is that the median time from last seen well was 11 hours. So there are patients who were last seen well 20 hours, 21 hours, and they were enrolled in the trial and received IV TPA. And out of the 80 patients they had, only one patient had a symptomatic intracranial hemorrhage. So they were able to show that you can safely select patients by MRI to receive IV TPA. And in a second, I'll show you their outcomes. In this slide, I've shown you that they found it to be safe. But before that, I want to mention one other trial that's called the Wakeup trial. Now, this was a much larger trial. They had almost 1,400 patients, and they essentially did the same thing. They selected patients by MRI with positive DWI and negative flare imaging, and they just finished enrollment in June. And while we don't have the full publication, we do have some of their preliminary results. So on this slide, you'll see the modified Rankin score distribution at 90 days for both of these trials. So the Eyewitness trial, if you see the blue bar and the red bar, they show a modified Rankin score of 0 and 1 respectively. They had 43.5% of their patients essentially have no disability. A modified Rankin score of 0 or 1 is essentially no disability. And the Wakeup Stroke trial, which had even more patients, more than 50% of their patients had no disability. So these researchers were able to show that we're able to accurately select patients using MRI who are 20 hours from the time that they were last known well to receive IV TPA and in a non-invasive way reverse their stroke. This trial is worth mentioning. The same people who published the Eyewitness trial are actually just starting another trial called Eyewitness. And while they were able to show that you can select patients using MRI to receive IV TPA in the context of wake-up stroke, they want to look at CT perfusion for the same thing. And so they're actually selecting patients by both CT perfusion and MRI, randomly assigning them and trying to see if either one imaging modality is better than the other or if they're equally effective. Because as we know, it's much faster to get a CT than it is to get an MRI, and many more patients are eligible for CT than MRI. So if we can use something as simple as a CT perfusion to select patients with wake-up stroke to receive IV TPA, it would include so many more patients to be treated. So these results are still to be announced. So switching gears just for one more second, what is the dreaded complication for giving IV TPA? It is the post-TPA intracranial hemorrhage. This is why nobody wants to give TPA, outside of the 3-hour time window, and somebody who's old. Nobody wants to see someone have a symptomatic intracranial hemorrhage. What if I told you that we could figure out who's going to have a hemorrhage and target treatment to those patients so that they don't have a hemorrhage and make it safer for them to receive IV TPA. This has been looked at, and there are ways via CT perfusion to find these what they call permeability hotspots. And they're the areas with the highest amount of blood-brain barrier breakdown, and this is where patients are likely to have a post-TPA intracranial hemorrhage, and they've shown that using this technology we can figure out exactly where and how large the intracranial hemorrhage will be. So if now we know how to predict who's going to have an intracranial hemorrhage, we can actually target treatment to prevent this. So there have been some smaller scale trials looking at strategies to expand the TPA time window. Several of them have been done in humans, and they're basically using medications that are known to stabilize the blood-brain barrier. The human studies have looked at medications, and this is actually published research, unfortunately on a very small scale, so not generalizable to the entire population just yet, but progesterone is known to stabilize the blood-brain barrier, and it has been shown to reduce TPA-related intracranial hemorrhage. The same is true for minocycline, and the same is true for silostazole. A few studies have looked at the same thing in animals, and what we have been able to find in animals is that candesartan as well as bryostatin, both by their mechanism of stabilizing the blood-brain barrier, reduce intracranial hemorrhage in animals after they have received IV TPA for stroke. So what I hope I've accomplished at the end of this, I know I only had a couple minutes, was to let you know that when you think outside the box, you can really find such surprising and shocking things that do benefit our patients, and the IV TPA story has not yet ended. Thank you.